Well, I'll go ahead and give an introduction then. Dr. Kate Bechtold, we're so pleased that you can join us and present today.
So I mean, I'm happy to maybe jump in and then, Kate, just for time, because we're, I think, about 4 minutes afterwards. Yeah, this, I mean, we invited Dr. Bechtold to give what we're calling quality and safety rounds, or M&M, really to try to illustrate kind of cases that we're all involved with, challenging. Oh, okay, I gotcha. Is Abby? Sorry.
That's okay. I'm not sure Eric can hear me, but we'll just roll with it. And as Eric was saying, the background on
Abby,
quality and
if you're
safety.
speaking, maybe it's on my end, but I can't hear you. I
It's
apologize.
just you.
Yeah, we can hear you, Abby.
Thanks. But welcome, Dr. Bechtold, in presenting your patient's expectations versus services rendered, and that importance of informed consent. I think this is an experience that, while not too common, we none of us want to be in a position where we do experience this, and we benefit from your ethical knowledge and reviewing of these cases so that we can all learn from your experience. So thank you so much.
All right, so can everyone hear me? Yeah, okay, great.
Yes.
So I'm going to just go ahead and dive in.
Sorry about that.
I don't have any disclosures that are relevant to the case that'll be presented. What I'm hoping to do is for all of us to learn from this case so that we can forge a path forward. And in that, I'm going to offer a description of what our clinical evaluation services are versus legal forensic evaluation services, and the differences and why that's important. And then identify elements of informed consent and steps that we can take to reduce risk of a defect happening again, like I experienced. So what is the defect situation? So a clinical evaluation services were rendered that did not match for what service the patient wanted, resulting in patient dissatisfaction and a claim of harm to her disability claim. So what actually happened? So I received a referral from a physiatry colleague to do a neuropsych eval because this person was experiencing some cognitive issues related to having long COVID. And the question was, what would be helpful for this patient given the cognitive complaints? That referral came in, and within a month, I was able to get her in for an intake to find out what this patient was experiencing and to devise a plan. And so did this intake virtually because the patient was actually living out of state with family to receive support because of the symptoms that she was experiencing. And it just matched better for her to do a virtual evaluation rather than come all the way back down to Maryland to do it in person. So with the results of that, it was clear that this patient really was struggling with fatigue issues, dizziness, and some brain fog, or some feelings that her brain could not do what she needed to do consistently for her to do her typical life activities. And so after doing that intake evaluation, I said, yes, we should go forward and do a full neuropsychological evaluation to really find out where the breakdowns were occurring. And also, after consulting back with my physiatry colleague who referred the patient, determined that we could get her started on some PT and OT services, and for her to go forward with that evaluation and treatment so that those other symptoms could be addressed and reduce that functional impact. However, the patient had some other medical conditions develop, so that delayed the additional services. So didn't begin the PT and OT services at Hopkins until approximately 5 minutes after I saw her for intake, and then didn't return for the neuropsych val until 10 months after completion of that intake, just to match up for what the patient had going on and being able to travel back and forward between staying with her family members to get support. So the patient did come back and attended in person for the evaluation to do the neuropsychological evaluation. And as part of our standard procedures for outpatient evaluation, we do an informed consent process. And in that process, we have an element of that to clarify, you know, what this evaluation is focused on. And the piece here is to ensure that the patient understands that this is offered as part of their clinical care and help diagnosis and recommendations for treatment, and that it's not serving as a purpose to talk about disability benefits, or if it was involved in a legal case or some other pieces of that. And this is actually her signed or initialed statement here that said that she understood that this was going to be part of clinical care, and that was the focus of the evaluation and what we would do with the results and recommendations. It's focusing on helping her. So I completed, along with Dr. Colby, a comprehensive neuropsych evaluation, which included a little bit going back, because it's now been 10 months. So we really did more of a full eval, stepping back, as well as doing the testing to look at how all the factors could be affecting the processing of information, and then to determine what intervention service might be helpful to address those persisting symptoms, and of course, you know, the ultimate to help her function better in daily life and return to some of the activities that she wasn't doing because of those symptoms. So, after the evaluation, I got with the referring physiatrist and to discuss the results, which basically were that this patient's cognitive functioning is intact, which is fantastic. However, it was being thwarted or distracted by some other symptoms, including mood-related symptoms, anxiety response, as well as distracted from the dizziness or the experience of dizziness, and the fatigue issues, having difficulty exerting herself. So with that, we said, let's do a joint discussion with the patient. And so we had scheduled with the patient for the physiatrist and myself to be present with the patient to discuss. The patient unfortunately had an acute minor medical event, and so I had to cancel that appointment. And so to follow our standard procedures, I had to get the report documentation on the chart in a timely manner. And so I did that. The patient read the report in my chart, and it really felt that this was problematic, the report and the findings of her having intact cognitive functioning, and the recommendations for her to focus on getting more comprehensive and robust interventions for her mood and anxiety and dizziness and building endurance. So she asked that Johns Hopkins made a formal request to restrict her access to her medical records because she felt the results of the evaluation would harm her disability claim with her insurance company, and that the report be redacted and corrected to answer questions regarding the course of her condition leading to disability and specifically her inability to work. So this is a snippet of that patient really sharing what she felt was the harm that was done. And so the bottom line is the patient was quite dissatisfied with the services rendered, and had very strong fears that the results would harm her ongoing disability claim that she is unable to work. So that's the incident. And so, in stepping back from this, Dr. Colby and I were able to step back, along with actually help with from Eric and people from patient safety and other folks, and say, why did this happen? And so was able to take this from a bigger picture view to really look at the different pieces and how that can help us to understand it and have a path forward to reduce the chance of a defect happening like this again. So one piece was that I made an assumption that we were answering clinical questions, given that my physiatry colleague referred the patient and asked specific questions to me about how we could be helpful in providing clinical intervention. So made an assumption that's what I was answering was purely a clinical question. There was no discussion of other goals with the patient at the evaluation at the initial intake. So when I did the virtual intake, I did not discuss with her. I did do an informed consent or assent, given that it would be verbal, given that, and she didn't mention anything about disability determination case or anything about any question about her returning to work or those pieces. It really was about the symptoms and how they were affording her care. So I didn't have a discussion about those other pieces. And then as you saw that during the neuropsychological evaluation that happened 10 months after the intake, despite doing informed consent process prior to that evaluation, specifically discussing and her initialing her understanding that the goal of the evaluation was determining clinical care, there was clearly not mutual understanding. So at the time of the consent, patient did not notify that she also wanted a disability determination evaluation, and after the fact, probably several months later, she actually notified that she had a request by her insurance company for a disability determination evaluation, but that was not we weren't notified of that at the time of the neuropsych eval. And did not explain that there are several differences to the patient, didn't take the time to explain there are several differences between a clinical evaluation and a disability determination evaluation. So that information was not clear, thus contributing to the mismatch potentially between the services rendered and the services that were being thought that she was receiving. So then we go, well, how can we reduce the risk of that defect happening again? And so the overarching point that we've all come from our analysis is that we're hoping that all rehabilitation clinicians recognize and be mindful that evaluations of functioning are pursued by folks that come across our doorstep for a variety of reasons, and to explore those reasons with the patient during the informed consent process. And for us to think about avoiding assuming that just because a clinical colleague referred the patient to us, that the reason for referral is to answer a clinical question, one, and that the evaluation is medically necessary, so otherwise should be billed under and paid for by the medical benefit or by the health insurance. So what can we do? Ask patients their reasons they are wanting. What are they hoping those results will be used for? What are they thinking that, okay, I wanted to help guide, what can I do to help myself get better, get stronger, get back to doing X, Y, Z? And I'm hoping that it can be used to support my disability claim or what have you. So asking patients their reasons and making sure that to give them that opportunity. Specifically identify for the patient the potential reasons that someone with a presenting condition symptoms could be referred for an evaluation. So otherwise, actually, there are many reasons why someone might be referred for an evaluation of their functioning. And for us to really step back a minute and understand those reasons. So the one we're most common, that's a problem for us because we're clinicians, is to identify, diagnose impairments in structure, function, or engagement, and identify targets for intervention and treatment. That's why we do an evaluation. We are clinicians providing clinical services. And so that's our assumption, and that's the assumption I made based on the referral, based on all these pieces. However, there are other reasons people pursue evaluation with a rehabilitation provider, and those fall under the realm of legal forensic evaluations. And so why would they do that? They would pursue that for access to insurance benefits related to an injury, illness, or disease process, because of the impact on their daily life functioning, or other people think their functioning is in question. And the goals of those evaluations can include a wide range. So disability determination. Does this person have a disability that affects their ability to engage in employment? And so that is usually, that's the payer for that is the disability insurance coverage. And so they're looking for whether they are eligible for those benefits. It's a benefits eligibility question. Another one, has the patient reached maximal medical improvement? So usually those questions are because that person has been injured on the job. And so what is their impairment rating? And so having an evaluation to look at whether they've reached MMI. And it usually, this question comes from workman's compensation benefit insurance company looking for that eligibility piece. Are the impairments impacting a role in life? That means that there's a legal role, a role that they're playing. So custody of children, legal contracts, guardianship. So these types of legal questions, and usually, these can come from this question by other people saying, does this person have those abilities to engage in those roles? And then finally, there's the ones where it's looking for compensation. So an injury has impacted that person, their functioning, and does that person deserve compensation? So there are key differences between a legal forensic evaluation versus a clinical evaluation. And understanding these gets to the root of why these are separate evaluations, and that you can't do one in together. And for us to all consider that knowing which type of evaluation is going to help us know how to guide our patient who is in front of us on whether they are going to get that goal met. So the first piece is who is the patient? And so with a clinical evaluation, our patient is our patient. So otherwise the client, the person walking in the door, is the patient. Whereas in the legal and forensic evaluation, there is no patient. The client is the entity requesting the evaluation. Secondly, the goal is different. So the goal for a clinical evaluation is to answer those wonderful clinical questions. How can we be helpful? How can we reduce some of the symptoms? How can we improve functioning? What is the diagnosis, and what are the treatments for that diagnosis? Whereas the goal of our evaluation to answer legal forensic questions is really to answer the questions of the client, that insurance company, that lawyer, that judge, that employer, about what they want to know about that evaluee. And here, one of the key pieces of differences between legal forensic versus clinical is whether it's an independent evaluation, which most people understand the terminology in IME, independent medical evaluation, but independent is the key word here. So forensic legal evaluations are independent. No clinician-patient relationship is established. And so that is completely different than when we do a clinical evaluation, where we are establishing a relationship and we have duty to do no harm. And so those are separate roles and separate relationships. And so you can't have both relationships. You can't be independent and dependent at the same time. So moving on, so the evaluation is requested, to answer those clinical questions versus legal forensic question, and finally, who pays for the evaluation? Otherwise, what undergirds this? If it's a health-related issue, and it is medically necessary to do the evaluation and get the treatment, then the evaluation is deemed medically necessary and the payer is that health insurance. Whereas if an evaluation is not medically necessary and it is under this legal forensic, the payer is not medical insurance, and it is actually fraudulent to use medical insurance to pay for such evaluations. But those pieces aren't well fleshed out. I think most clinicians aren't taught this information and don't understand the differences that are present between those type of evaluations. We just want to help. We want to help folks, and providing, okay, yeah, I can answer whether you have a disability. And so it's really understanding what role you're playing and how you can answer and help without necessarily shifting over and into a different realm of evaluation role. So do ask the patient to state whether they have a disability claim to their insurance company or have a legal case pending related to their condition. It's okay, they can have those. This patient had that going on, was using her disability benefits because she was on long-term leave related to her symptoms. It just wasn't clear that she had a question of that, and that she had a legal case going on. Those pieces she hadn't, hadn't notified about. So if yes, ask if they're pursuing this particular evaluation with you in support of that claim or legal case. And if that yes, then refer them or encourage them, or encourage them to pursue that independent evaluation. So most of the time that is something that when that has been recommended, it will be paid by that disability insurance company or get paid by the lawyer. And that person can play that role of having no clinician patient relationship and can do the evaluation from that independent lens. So you want to, provide them that guidance of saying, hey, that sounds like a really needed service for you. And these are, that this is what you need to pursue and talk with your lawyer, the disability insurance company about to get that set up. So in what we can do to make sure exploring those goals and making sure. So I would recommend that we ask patients to read and sign a statement, which we did in this situation. But not only doing that, I think going beyond this, laying it out in words and having initial is having a discussion that they understand and being able to describe those elements of what is an independent evaluation versus the clinical evaluation that they've been referred for, that they've at least come to you that day for. So ask the patient, though, as you're going through the process, to let you know if the situation changes. I think in this situation, there wasn't, although she was using her disability benefit back when I did the intake, by the time 10 months later, when Dr. Colby and I did the comprehensive neuropsych eval, we didn't ask, has anything changed in terms of your disability determination status or whether you have a legal proceeding? We did not ask those questions whether status had changed. And I think that would have been helpful to elucidate that this patient had multiple goals for her evaluation. And then the other piece would be to update the referring provider and other team members about the change if relevant to ongoing care, to ensure that they're aware that the patient has multiple goals here, so that they know when a patient's asking about, well, can you write me a letter that says I still need to be off of work, or those pieces that your teammates are aware of the variable goals that are present for this person. So in thinking about how we know the risk is reduced, this is, I think, yes, a QI project could be done to look at. Might be, challenging to do, as most QI projects are. But I think, if we all take a concerted effort to have a consistent use of an informed consent procedure, where the informed includes those eminent elements of being able to say, hey, there's multiple reasons people pursue an evaluation. What are yours? Well, do any of them, it sounds like you have some clinical goals here, and that you're at the right place. We can help you with that. Do you have any other goals, such as that you have a lawyer that's helping you with because of your injury? Or do you have a legal case that is looking at who's responsible? Or do you have a disability claim, and you're trying to demonstrate that you are still have a disabling condition that keeps you off from work? Having that more robust discussion means that when the patient consents to the evaluation, they are truly informed about the evaluation they're going to receive. And I know it's a little bit of, us having the written documentation of this, that I'm asking, for people to do this both verbally and in written, so that you have the person's written acknowledgement. I do say, though, we all need to remember that when humans read something and need to sign something, they're actually munching on the information in multiple ways. And so it also helps them to think it through and go, well, wait a minute here, I'm signing that it isn't related to that. So it can help them at least think through those different elements. So it is going to add a few minutes, but I would say that the benefit from the perspective of the patient to be able to look at and understand that they may have many goals, and that we understand those goals, is going to reduce the chance of there being misunderstanding. Because, one might argue that there, was that the patient's dissatisfaction could be rectified by, okay, so go get an independent medical evaluation, and then you should be satisfied. You got the clinical services. We continued to, work with the rehabilitation team and got what you needed. I would say that because of the misalignment of not understanding that the evaluation was going to not answer the questions that the disability insurance company had, and that there was a misalignment to her feeling like she is severely disabled by her cognitive problems, when in fact there was no evidence of severe cognitive impairment. I'm not, it's going to be challenging to some degree to rectify that type of situation, but at least she wouldn't have looked at this evaluation in that way. The final point that I want to make is one about something that I hadn't thought of, and that I learned, or at least reinforced in my head, which is when there is knowledge that a person has a disability, they've invoked their disability insurance, and is that insurance company has access to all of their records related to the injury or illness that's related to the claim. And so we usually think about confidentiality being, well, the payer So her medical insurance paid for this. And so we know that they get our CPT codes and our diagnostic codes and, those pieces. But otherwise, and then the team would have access. But there was this piece of confidentiality where she was well aware that the disability insurance company would have access to all her records. And I hadn't fielded that. I hadn't thought about, that they're just reaching in to the record and yielding all of that information. And so it's a piece that was a learning curve for me to understand that. So I think this is more of a situation where it will be benefit from all of us thinking about it and consulting with one another's when these types of situations arise, even in the moment. And but I'm not sure on a departmental level whether there's anything we can do to know how we're going to reduce the risk. But I love anybody's ideas about this.
Kate, can I think one of the, it's not often, I mean, legal gets involved, like risk management and things like that, but maybe could you just share your experience? Because I think one thing that's helpful to know, us working at Hopkins is that we do have a team that's supporting us. And I don't know if you wanted to just speak to that a little bit, because I think my impression about this case was, this was a unique situation for you, right? And you were just like, it was like, wow, like, there's a lot going on here and things like that. But can you speak to a little bit about that? I think the faculty would benefit from hearing that.
Okay. Yeah. So Eric had the joy of having me go, what's going on? So in my 20 plus years here at Hopkins, I have never had a patient say that they weren't happy with the services I rendered. And that, so there was a couple of levels that happened. So the patient asked, as I already said in the presentation, for the record to be, well, she said redacted. And of course, there's a education piece, but so do an addendum. She requested an addendum. And so how to navigate that. But also the patient was quite distressed. And so because there, was a question of whether my services were what should have happened and whether I followed standard of practice and those pieces, legal was involved. And so it was being able to step back and look at the way that particularly the informed consent procedure and talk with legal about whether I had done what should have been done. And that luckily for, I felt supported by legal because they analyzed, actually a whole team of people analyzed this 60 ways from Sunday. Thank you, Eric, for your tons of hours on this. And we're able to look at it from a documentation standpoint, a consent standpoint, what was the patient wanting versus what they got, and just all these pieces, and being able to navigate that so that being able to put an addendum on the chart that helped to answer some of the patient's concerns on the report while being true to what were the clinical findings and recommendations, but more in a supportive stance that hopefully allayed some of her concerns, but then also being able to partner with department and legal and patient safety folks on how to respond to a patient that feels like they've been harmed. So I don't know, Eric, if you want me to say anything else.
No, I think that's good. I mean, I just, again, I think it's just a good reminder if the situation comes up that you're sort of, maybe a patient's claiming something, or, that you're just not sure about. I think it's a good reminder for folks to know that there is a resource here at Hopkins, including the legal team, the risk management team, things like that you can reach out to get some advice, and I think that they have a lot of experience, and they're dealing with a lot of stuff. I think they sort of normalize the case a lot, and kind of put the because it's I think as the provider you're just like, oh my God, this is like a crisis kind of situation, and I think they were helpful to at least kind of put things a little bit more, maybe take a little bit of the steam out of that, and really help us kind of work through that, and give us some, like, I would say, like, somewhat of a framework to support. So anyway, I just thought that was an important part of the case that I wanted to kind of highlight. But Kate, one thing I would really, if you, I think these slides were excellent. If you could maybe share, if you feel, if you could share, especially some of these like lessons learned and things like that. I mean, I would love to kind of keep this in my, like, folder of things if I ever have, to consider. Cause I think one on my end, as of, on the physician side, I think you're right. I don't think and I'm guessing a lot of the colleagues are probably not really thinking about, when you're meeting a patient, really trying to assess the goal, like the purpose of the visit. I think we just kind of go into mode of like, oh, this is for clinical treatment, and we just kind of go into that sort of mindset. But that might not be the reason for the visit, and I think we have to be really thoughtful about that. I think Marlise had her hand up. Marlise, did you want to ask a question or make a comment?
Yeah, I think this is a very interesting, Kate and Eric, thank you for putting it together. And I think it in my brain, it raised a lot of questions in terms of what, we are all clinicians, we're taking care of patients and doing our best to serve them. And these intersections with the needs for disability and so forth are perhaps even more prevalent in our groups than in others. So it's, again, I don't have any answers, but it just raises all these questions like, can we support that being done? And from a physician standpoint, I think it's as tricky because, again, we are not doing an IME, we're not doing an independent evaluation, but patients know that all these documents are discoverable in all those cases and have to agree for us to share those documents. So it is this gray area that we have to live in because of the work we do. That is, again, I would appreciate any comments as to how we can support this at a department level in a way that's meaningful. I'm not coming up personally with many ideas on how to mitigate it, except for, again, the one-on-one consent process that really should be clear for patients. But obviously it was, again, we could argue about how it was obtained, but it was obtained in this case and it still caused problems.
Yeah. Yeah. And that was legal's point. So just to reinforce Eric's comment about legal were so helpful. I mean, early on, just taking, I mean, I called the hotline and so, and then the safety, patient relations folks, I mean, people will talk to you. And so to do that. And then, I would say that my main takeaway from this, Marlise, and that on a departmental level is this being really clear when you walk, and to do this, integrate this into our training programs for people to know when a clinician crosses the threshold, what hat they're wearing. You can write a letter that says, hey, you're ready to return to work, right? Or that, this person has an ongoing disability that's related to XYZ. That is not doing an IME. So knowing what role we are and then being clear with the patient, I am your doctor, I am your clinician, I am your therapist. that's what role I'm playing. I cannot I cannot say that I did an independent evaluation because I'm not independent. I am duty bound to do no harm, which, that's a longer discussion to think about. If you're asked a legal question, as a clinician, that you are going to out yourself and saying, I'm not going to say anything that's going to be harmful to my patient. I'm not going to, give information that's necessarily going to negatively influence them or impact them. And there's all sorts of conclusions at times, including in this case. So this patient got what should be positive news. Your brain, it can work, it can do it, it is inconsistent, and here are the reasons why it's inconsistent, and therefore these interventions are what's going to help you. But the outlook is great. There's a path forward here. You do not have permanent damage. You don't have, an injury to your brain. That should be positive, but it was viewed as negative because it didn't support her disability claim and what she had claimed on her disability.
Yeah.
And so, yeah.
And I wonder if at some point we could check with legal as to like how, of course, the patient has to agree for us to release records to any entity, because again, our responsibility is to the patient. On the same token, it's like, can a patient pick and choose what is delivered to those folks? And I don't know if legal gave you some advice as to that.
Yeah, so that was one of the ahas that I had at the end. So when it comes to a disability determination, so if they've invoked that they are using their disability benefit in order to be off from work, that they give unfettered access to that insurance company to see all medical records related to the condition, injury, or an illness. And so they don't have a choice. They have to sign that. But that was an aha going, oh, as opposed to them choosing, oh, well, I'm getting clinical care for this. It's paid by my medical insurance and, and that's over here. That's not the case when it comes to disability determination.
Yeah, again, a very difficult area where we certainly are going to face more and more patients having similar situations. So thank you, Kate.
Are there other questions or comments? This is anything, even just a commentary is going to be helpful for us to be on the same page. Yeah, Abby.
Hi, thanks so much again. While these instances are very rare in the grand scheme of how the sheer volume of patients that we can see based on the time spent in this presentation and the hours you, Eric, quality team, legal spent in addressing this patient's distress and perceived harm within this process. We aren't alone as a medical system or as a department in these issues coming up, and different psychology groups and other medical groups have likely thought through some of these things, even at the level of scheduling on the front end. I know some of our patients are asked off the bat before they schedule, are you currently involved in a workman's comp claim, as one potential question. Kate, just from your various consultations, your role on ethics committees at the national level, other settings you've worked in, are there, at the department or at the pre-appointment level, are there ways that you think have been successful in potentially identifying these patients who may be at risk of entering into their own ethical gray areas because of, on one hand, their desire to get treatment and care and reduce their suffering, and on the other hand, pursuing what they feel is a justified legal right and process?
So my understanding from talking with other groups in various roles that I have at a national level is that nobody has instituted any type of question line that really gets at it, because what nobody wants to do is have a patient not get in for care when, even if it's only one of several goals, is clinical care. And so people find that at the screening, not by professional levels, but by front line staff, the screening questions of, you know, are you involved in a legal case related to this, or are you, that doesn't mean that that person's goal isn't to get in for clinical care. And so the answer is nobody's figured out how to do that, because the sophistication of questions and understanding, which we just grappled with, is really at the professional level to understand this, right? How can I be helpful wearing firmly my clinician hat, because that's the only hat we wear? We can still provide supporting information in these different realms, but what we can't do is take off that hat and put on an independent examiner hat. We can't. And that was a piece also reinforced by legal. We cannot do IMEs, because we are entering into a doctor-patient relationship. And once that's established, you can't be independent. And so, you know, maybe we can become more sophisticated, asking some questions at the front end, just so, you know, we get to it. So I can think, you know, okay, so you've been referred for an evaluation, you'd like to have XYZ, sees XYZ doc or clinician. Do you have a legal case related to this? Who will be paying for this evaluation? Your medical insurance, or your or the lawyer, the law firm? And I can see that could help us. However, even patients don't understand this. We call it the lawyer in the wood box, because he's sitting there looking out going, hey, just go get your doc to do this, and then we don't have to pay for it, kind of thing. And I know that's sort of a nefarious conceptualization of it, but that is a concern nationally, is that patients come to get a forensic eval under the auspices of it. Well, it's, you know, just get under your clinical care, and then we'll use it, and then we don't have to pay for it. Your medical insurance will pay for it. So I just think there's many complexities here that patients aren't aware, we're not aware, and it makes it challenging. Steve?
Yeah, Kate, I think this is a great talk, and your two columns showing the difference, I think, was a very, very educational piece, because many of us either don't know or have forgotten the distinction between these two things, the various roles and the various goals. Let me just first say is, I think, you know, you and the division have been very forward thinking in having this consent form people sign. I mean, on the paper, it says, this is what this is for. I mean, so legally, she has no case. Now, patient satisfaction is a different story. Yeah. But I want to commend you and others in the division for coming up with this form that routinely is used. I think that's very important. I think the other thing we should think about is that, as you are raising, I think Eric raised too, is that given the kinds of people that we work with, many of whom are injured in many different ways, right? We should have a high index of suspicion that people are engaged in disability process or in legal processes. So I think as clinicians across our disciplines, it behooves us to ask people as part of our intake with them is, do you have litigation pending? Right? I mean, we know that behavior is a function of the person and the environment. And if a person is working in a context of a legal case, understanding how that may affect their responses to treatment, how they respond to questions, you know, is something that we should know, regardless of whether they want to use it for a legal purpose, understanding the context of their illness in terms of, are they engaged in a legal process That's useful to know in understanding them as a person. It may also catch this problem and say, well, let me be clear. I see you told me you have a case pending. What we're doing today is not part of that legal process. This is part of your clinical care. We want to be clear on that. I mean, so I think we should have a high index of suspicion of understanding if patients are involved in disability process or in a legal process, because it helps to understand them and their circumstances. And we may catch one of these a little bit earlier in the process. But I think your work with the form is extremely diligent. So I think I understand there are two issues here. One is the legal risk we have, and the other one, of course, is the patient satisfaction risk and trying to assist this woman with a very difficult situation and having her feeling alienated from providers who are trying to help her. I mean, there are multiple factors, but I think you did a great job on the legal side of it, you know.
Yeah, I think, even just thinking about, right, what can we do? Having it in writing, having the conversation, and us taking our training mission where we are integrating this piece of education into what we teach our trainees, because I don't know about any of you, but I didn't get this in training. And so, it's just not part of what we typically munch on. Rachel?
Hi, Kate. Amazing presentation. I'm learning a lot. Thank you for delivering us this education that maybe we didn't get at earlier stages in training. I thought I'd share one reaction that's coming up for me. I agree with Steve. We've got a great consent form in psychology, and I'm so grateful for the people who put the work into putting that together as a guide. One thing that's jumping out at me is that piece that you showed us in the beginning that the patient had signed, with the language about this does not determine eligibility for workers' compensation, et cetera, et cetera. When I'm going through that consent form with patients, I think of it as a conversation. So I'm not reading it word for word. I'm giving the information in my own words. I'm assessing their understanding, as we go along. But I always read that blurb word for word because I don't want to get it wrong. And because, we've had stories in the division of that being an issue, but it's just occurring to me listening to this presentation that there's just so much that blurb requires so much knowledge. And, I think in my effort to ensure that we're on exactly the same page, I'm reading it word for word, but really that's like a section that needs a lot more attention and expansion. So I know that's just a takeaway I thought I would share, just the importance of educating the patients about like what that really means, because even the word like eligibility for disability means different things to different people, and we see that kind of clearly all the time. Like, does that mean social security disability, or does that mean like I need an ergonomic chair at work, and so there's just so much of a range in how people even make sense of those terms.
Yeah. And thinking about maybe, even a script that helps us, right? That is not necessarily in the form, but helps us have this discussion of what are, let's talk a little bit about what are the differences, just because this is important. I want you to get the services you want and that you need. And I want to make sure you've come to the right place, right? And so this is what I can offer. And if you need these other pieces, but like you're saying, Rachel, we have to have the language. We have to understand it. And there's just not a strong understanding. We're not taught this stuff, and we don't discuss this stuff. And so, opening the door that, hey, let's consult with one another. Let's maybe come up with, a more, maybe even a consent form that is something we use department wide, and then also have a script or some other, more in-depth explanation so that we know how to walk through that conversation. Well, I'm mindful of the time. Are there any, parting? Yes, Jackie?
Yeah, thank you. I do have a question. So I was just thinking about what this looks like what this would actually look like in clinic. And so if that patient had actually during that appointment said, yeah, this is for my clinical care, but because I'm currently receiving SSDI, or disability benefits through with this company, they do have access. Like, they do review my records every year. Because I've had patients who have been in that situation. So even though it's technically for a clinical purpose, the fact that they're receiving these benefits necessitates that their insurance reviews their records every so often. What would what would be the best course in that situation?
Yeah, so that's such a great point. So now moving forward to them consenting, but also understanding in that they're consenting for that their confidentiality of this information does not extend to that disability company will have access to the records. And so to include that in the confidentiality piece of the discussion for informed consent of saying, so you have a disability claim, you are on on leave because this condition is affecting your ability to function and to work. And so there'll be ongoing review of that claim by that company, and they will be accessing your medical record and any record. So I think it's part of the consent process so that they go, oh, well, wait a minute here, okay. And so just being mindful of that, because then they can give their permission or not. They could consent, or they could say, oh gosh, I'm not sure I want them having access to this. I mean, it's part of the process.
Yeah, that's really helpful. Thank you, Kate. It puts patients and us in difficult situations because yeah.
Yeah, and to Eric's point, this is part and parcel of what we do. I mean, these are, I mean, that we serve individuals with chronic conditions and disabilities. I mean, that's what we do. And our goal is to reduce disability and help people engage in life in meaningful ways, regardless of what profession we are. And so that there's going to be this interchange in these realms.
Just before time, can I just put a quick plug? I mean, I think the discussion was amazing in this talk. So Kate, thank you so much. I guess I was just going to say is, I think these are honestly the type of topics that are great, I think, for people to think about and share about. So I think if you're, in your clinical practice and, complex situations come in and there's an opportunity again to kind of share and learn, please bring these forward, to myself, as, particularly, whether it's psychology or, we're not limited to like mortality events anymore, like it really can be broader than that. And anyway, I just wanted to say thank you, Kate. This was great. Please share the slides. And again, just for the rest of the group, if these opportunities for learning for the rest of them, I please bring them forward to us.
Thank you all for the discussion.
Thank you, Kate. Bye-bye.
Bye.
All right, bye everyone.